Okay. Hi, everyone. Welcome to the Division of Rheumatology Grand Rounds. Thank you for joining us. Just a couple notes before we get started. You'll see that we have both a chat function and a Q&A function. Please type all of your questions in the Q&A function to keep them consolidated into one place. Dr. Ott is going to save about 10 to 15 minutes at the end of her lecture for questions. And also, if anyone would like to ask their question face-to-face and would like to turn on their camera, you can just raise your hand and I can upgrade you so that you'll be able to ask Dr. Ott directly. And now I'm going to pass things off to Dr. Julie Karkin. Thank you.
Good morning. Susan Ott at University of Washington doesn't really need an introduction, but I will anyway for some of our fellows and people who are new to UW. Dr. Ott is a nationally and internationally known expert in metabolic bone. She's board certified nephrologist and a professor of medicine at University of Washington, also adjunct professor in radiology and orthopedics. Dr. Ott has over 130 publications in refereed, peer-reviewed journals and multiple book chapters. She's had a number of honors, and one that stands out to nephrologists is that she was invited to give the Jack Coburn memorial lectureship at the American College of Nephrology, which is one of their society's highest honors. And they know she's a great speaker. I know she's a great speaker. I think you're going to enjoy this. Her lecture today is entitled Seductive Short-Term Effects of Osteoporosis Treatments. And she saved some time for Q&A at the end, and we'll all be sipping on our coffee and can have a lively Q&A. And so please join me in welcoming Dr. Ott. And Susan, welcome and thank you.
Okay, you're welcome. Am I on now? I hope.
Okay. You are.
Okay, and so you all can see the screen. So I'm going to be talking about the seductive short-term effects, and we're trying something a little different. I actually pre-recorded myself. So I'm going to run this, and I can answer some of your questions during the talk if you want, or we'll wait, and there are 10 minutes at the end. So here we go. Talk about the seductive short-term effects of osteoporosis treatments. And I have no conflicts of interest. So this slide shows that both age and bone density predict fractures. And the fracture rates really start going up after menopause, and particularly after age 65. As you can see, even at the same bone density, the fracture rates really go up sharply with duration. But this is a long time span, 30, 40 years. And yet the duration of the randomized trials is relatively short compared to the duration of the age of fractures. The longest bisphosphonate trials are 4 years. Raloxifene and estrogen have had trials of 8 years, teriparatide 1.5, denosumab 3 or 4, and romosozumab 1 year. And we have very little information about what happens after we stop these drugs, or what happens if we try to continue them for a longer duration than was done in the trials. So that's what we're going to focus on today. But before I get started with that, I want to point out one other aspect about treatment of osteoporosis, and that is that it is totally ignored. And Dr. Karkin wanted me to please put some comments in about how often it's ignored. And this is a relatively recent study looking at patients who had been admitted for a hip fracture. This is a situation where everybody agrees that treatment is indicated, and yet across this country overall, lower than 10%, less than 10% of the patients who've had a hip fracture are given any treatment, either right after the surgery or even within 6 months or 12 months. So this is really dismal, and we need to pay attention to these fracture rates and treat more people. So I'm going to go through quite a few of the medications, and we're starting out with estrogen. And the Women's Health Initiative certainly is the largest trial and the longest duration. And many outcomes were evaluated with this study, but the one that clearly was the most frequent was fractures. And you can see that in both arms of the Women's Health Initiative, there was a significant reduction in the rates of fractures. And when you looked more closely, all of the kinds of fractures were reduced, whether they were hip fractures, vertebral, all fractures. They were reduced in all age groups, and they were reduced with both forms of estrogen and progesterone. A more recent study has shown what happens if you discontinue the estrogen after the Women's Health Initiative. And this shows the 5 years after women stopped. The one side is the group that received the combination of estrogen and medroxyprogesterone. And this side was the ones that received estrogen alone. And the fracture rates, looking at the total fractures, accumulated in both people and both groups, but the ones who took the estrogens maintained an advantage for the next 5 years after they stopped. And there certainly wasn't a more rapid increase than you would have seen anyway, just with aging. Similar findings were seen with the combination group, although in this case, there really wasn't much of an advantage anymore after 5 years. Many people have the misunderstanding that somehow bisphosphonates are more important or stronger, work better than estrogen, and yet none of the data shows that. And this is a randomized clinical trial involving 1,600 women who were between 40 and 60 years old. And they were followed for 4 years on placebo, alendronate, or 2 different estrogen regimens. This shows the change in the spine bone density, which was the major outcome of the study. And as we expect, in the placebo women this age, there was a loss. And the alendronate group did eliminate the loss, and they showed a slight gain in the bone density. But the estrogen groups, and particularly the estrogen norethindrome group, had significantly better change in bone density than alendronate. This was also seen in 4 other randomized trials that were done quite a while ago when alendronate was first on the market. And in each one, the estrogen was either as good as or better than bisphosphonate. You can see the actual increases in bone density here: 7, 7, 3, 6, and 6, 7, 1, and 7. This was the younger women, 10 and 9.1. And the one I showed you, 7.5, 4. So it's a myth that somehow the bisphosphonates are stronger than estrogen. When we look at fracture rates, as in the Women's Health Initiative, they're reduced in every segment, regardless of the bone density, and the quality of the bone is better. So in terms of the bone, estrogen is, especially in a younger woman who's in the early years of menopause, clearly better for the bone than the bisphosphonates. And as long as you're within 10 years of menopause, it's generally a safe drug. Now, before the Women's Health Initiative, it was common to use estrogen lifelong. And this was the results from the study of osteoporotic fractures, which recruited 9,700 women across the country in 4 different centers. It was designed to be a broad spectrum representing the population. And they had to be 65 years or older and able to come to the clinic, so they were ambulatory. This shows the results of women who were using estrogen compared to the ones who were non-users from the baseline of the study, at which time, because they were all older than 65, the mean duration of estrogen use was 24 years. And after 11 years of follow-up, so by this time, the women who were using estrogen had used it for 35 years. And during the entire last 12 years, they had lower fracture rates than the non-users. So even with very lifelong years of estrogen, there's reduction in the fracture. And if we look at hip fractures in women who were in their 80s, in the years before the Women's Health Initiative, when estrogen went out of favor, we could see that there were about a half to a third as many hip fractures. So with estrogen, it's clear that long-term use has continuing benefit. Okay, I'm actually changing videos here, so hold on 1 minute while I get my second one. Let's see, so that's part 1, and here's part 2. And now I want to show you a little movie of explaining the markers of bone formation and resorption, just because a lot of people aren't familiar with these, and they help you to understand some of the physiology that's going on when you use these drugs. So we start off with bone formation, and this would be an osteoblast that's filling in a resorption cavity that has just happened. And the osteoblast secretes the collagen, and the ends are cleaved off. Seen here, each end has a propeptide. And this one is called the P1NP, and that's a marker of bone formation, because every time you form a molecule of collagen, you're making a P1NP molecule. Now, the collagen molecules will then line up in a particular pattern every time with the exact same spacing, and they therefore will get a covalent bond here, and these are called pyridinoline crosslinks, as shown in red. This stabilizes the collagen, and it will remain in this configuration until it gets resorbed on an average of 5 years later. And meanwhile, an osteoplast will come by and secrete cathepsin, which cleaves the collagen. And this results in a lot of little fragments, one of which was on the N-telo side, and so we call the N-telopeptide and the C-telopeptide. These are our markers of bone resorption. So the more that you're resorbing bone, the higher these are. And they are a good measure of bone turnover. I will make a caveat that if you've just had a fracture, just the repair of the fracture itself causes the NTX and CTX to go way up. So you can't use these markers to tell what the situation of the bone was prior to the fracture. You have to wait at least 4 to 6 months. So now we're going to talk about bisphosphonates. And you're all very familiar with these drugs. They're recommended for virtually everybody that takes steroids. And for many people with osteoporosis, they're going to be the first drug of choice. Zolodonic acid is an example that I'm showing here. And you can see in this 3-year study that people who'd had a hip fracture and were treated with zolodonic acid had a significant reduction in the incidence of any fractures in the next 3 years compared to placebo. But there's much less data about long-term use. I counted up all the fractures I mean, all the numbers of patients who were enrolled in clinical trials of bisphosphonate that lasted anywhere from 2 to 4 years, there were about 35,000 subjects. This is the only one that has looked beyond that was randomized. And it only included about 1,000 women. So all of the women in the study were originally in the alendronate trial, and they had all taken alendronate for 5 years. At that time, they were randomized into continuing alendronate, 2 different doses, or to a placebo. This is what happened to the urine NTX. Now, this is the marker of bone resorption. So during the first 5 years of these patients, the bone turnover went way down. The NTX went from 70 to about 19. And since these were only the ones who had taken alendronate, this happened to all of them. And then, interestingly, at the next 5 years, so 5 to 10 years of taking alendronate, the NTX stayed the same, but it also stayed low in the ones even when they were switched to placebo. What this is showing is that you're having a prolonged effect of alendronate even if you're not taking it anymore. And that's because bisphosphonates bind to the calcium and remain in the bone for a long time. The half-life is estimated to be about 10 years. But what happens to the fracture rates? These are shown here. It's the best graphic that I've seen, and it comes from the FDA report, where they looked at the time to get a fracture in these studies during flex years 1 to 5. So they all been taking alendronate for 5 years at this point. And the ones in the green were randomized to placebo, and the others are still on alendronate. And you can see that there's no difference in the fracture rates, whether you take it or whether you stop it. There's no longer any reason to continue taking the drug because it's not helping with any of the fractures. Now, a lot of times you're going to see editorials and commentaries that if you have osteoporosis, that's a different story. But the FDA had already analyzed that. So they looked only at the women who had a T-score that was lower than -2.5. So this is the group with osteoporosis. It's a smaller group, but it clearly didn't help to take alendronate. So the placebo group here in green has the same fractures as the alendronate group, whether you use the higher or the lower dose during the 5 years. So it's just misquoted all the time that patients who have a high risk of fracture should stay on alendronate for prolonged time, whereas the ones who have a low risk can stop at 5 years. The data actually show that everybody should stop at 5 years, whether they have a high risk or a low risk, because continuing the drug is not helping with your risk. The new question is, well, is it making any harm? Is it harming your bone to stay on alendronate for a prolonged time? And I think there are some harms. And the first thing is that you are not forming any new bone. But this shows bone formation rates that are measured on biopsies from a study. Every dot is a study. These are normal adult women, women with osteoporosis. And these are the ones that are taking bisphosphonates. You can see that the bone formation rate is a lot lower in the ones on bisphosphonates than in all of the other groups of women. And in trials where they did pre and post measurements, you can see this steep drop, and these drops are about 80 to 95% decrease in the bone formation rates to rates that are really lower than we see in most normal patients. I'll point out that denosumab drops it even more, whereas teriparatide, and also I don't have it plotted, but romosozumab increase the bone formation rate. Does this make any difference? Well, I think it does, because you need to remodel your bone in order to repair damage. This is what we can see under a biopsy when you stain for damage with fuchsin red. these little cracks, we call them micro cracks. These happen in everybody when you stumble, when you get a little bit of a jolt on your bone. And as with any material, there's going to be some damage. And this will initiate bone resorption in a bone that hasn't been of patients taking bisphosphonates for up to 16 years, the rate of these micro cracks starts to accumulate. It's been shown now in several different studies. And in one study, they measured the strength using finite element analysis from biopsies, again, of women who'd been taking bisphosphonates for a prolonged time. And what they found is that the strength increased during the first 7 years and then decreased, whereas the cracks just increased the entire time. So during the initial part of treatment, the bone is actually getting stronger because you're no longer dissolving it, you're filling in some of the holes that had recently dissolved, you're adding a little bit of mineral, and this all strengthens the bone and can explain why there's fewer fractures. But after 5 years, the increase in the micro damage is starting to counterbalance the positive effects, and your strength actually starts to go down and your bone becomes brittle. And one of the things that happens with bisphosphonates is that the mineral accumulates. It's going to displace water because you're not refreshing the bone anymore. The bone's actually getting older and harder. The same thing happens to fossil bone. And of course, these bones are nearly rocks and they certainly have a high bone density. This is what explains the increased bone density with the drugs. And when you have petrified logs, they don't break in the same way that normal logs do. This log didn't break when it was a tree. It broke after it had fossilized, and look how sharp the break is. It reminds me of the x-rays of patients who've been on bisphosphonates a long time, and they have a fracture. And these are the atypical fractures. I know you've all heard about them. Just comparing them on x-rays to ordinary typical hip fracture that's so common in elderly people. Notice that the bone is thinner here in the cortex than it is here. The fracture line is either oblique or spiral, and there's splinters. Here it's just two pieces. The fracture line is a clean transverse break here, maybe a little peak on that side, and there's a flare often right at the place where the fracture is. And prior to a fracture, you can see a reaction often on the periosteum. This is a really bad sign. This patient who had some pain, she got a bone scan, had this lump. I was asked to review the x-ray and said, wow, she better come in right away. The next day she didn't show up, and she got this fracture while she was just getting dressed for the appointment. One of our first atypical fractures here at the university. Now these fractures do increase with duration of use. As we first reported this in 2012, a lot of people didn't want to believe it. But by looking at all the x-rays from fractures in Kaiser, Southern California, we could see the atypical fractures were very rare in patients who not been treated with bisphosphonates, and it starts going up progressively to 10 years when you're really seeing about 1 in 1,000 women getting an atypical fracture. This has been replicated now in Northern California. The same kind of pattern. They actually had a little bit higher rate after 10 years. And a very recent study a few months ago that was published showing even higher rates, up to 131 per 100,000. So that's more than 1 in 1,000 women. that's higher than the expected rate of getting an ordinary fracture for somebody who only has osteopenia. And the interesting thing about, one of the interesting things is that Asian women have 5 times the risk of getting an atypical fracture compared to other races. We have no idea why that occurs. So it's clear that atypical fractures increase. What's not clear is whether ordinary or typical fractures increase. But there is some suggestion from this observational study in the Women's Health Initiative that prolonged bisphosphonates may have a harm on even ordinary fractures. So they did an instance of fractures according to bisphosphonate use compared to 2 years of use. By the time they used it 10 years, they had significantly more fractures. And they had already adjusted for age. So this is not just because they're getting 8 years older. It's because they're actually having a higher risk of fracture. And these kind of studies need to be repeated, and we need to really try to settle whether you're getting not only more atypical fractures, but even more ordinary fractures. We tried to do the same thing in California. We didn't have this many people, but the idea of this study was observational of women who'd already taken alendronate for 5 years. And then we looked at how many ordinary fractures, ordinary hip fractures they had if they kept taking it or if they stopped. And 2 main lines here are the yellow line where they kept taking the bisphosphonate, and the yellow line was where they had stopped, and the black line is where they kept taking it. And depending on whether we allowed a 6-month period to enroll them, we got slightly different results here. But it almost was looking like the ones who took them for 5 more years were having more fractures than the ones who stopped taking them. There was no real significant difference here. This was statistically significant, but depended on a grace period. So it's not a clear-cut answer, but it does suggest that there may be something there to developing unusual fractures. So my take-home message with bisphosphonates before we go on is that you really ought to stop taking them after 5 years and not risk the brittle bone, the atypical fractures, and maybe even the ordinary fractures with prolonged use. Now, there's not that much long-term data about teriparatide because there's a black box warning not to use it. Just put this slide up to show that it's a very effective medication in both young and old people. These are the fractures compared to placebo. You can see the marked reduction. And the study only lasted 1.5 years. The longest randomized trial was actually in patients who were taking steroids. And I think you guys are all familiar with this 36-month trial comparing alendronate to teriparatide. And the main point was that the ones on teriparatide had fewer fractures. One of the things that was interesting was what happens to the P1NP. Remember, that's the marker of bone formation. And this is what's really wrong with steroid osteoporosis, is the osteoblasts just are not forming very much bone. When you treat these patients with the teriparatide, you get an increase in the bone formation rate that actually stays up above baseline, even up to 36 months. And I point this out because it's a little different from the osteoporosis trials of ordinary osteoporosis, where the P1NP is back down to normal after 18 months, or not normal, but back down to baseline. In the ones that were treated with the bisphosphonates, however, the P1NP got even worse, and the bone formation rate is even worse than it was with the steroids, and stays down for the duration of taking the alendronate. We do have data about what happens when you discontinue teriparatide. You lose what you had gained. And this is one study. There's been several where the bone formation, the bone density goes up, and then when you stop, it comes back down again. It doesn't rebound, but it comes back down, and it's a shame because you lose everything you gain. However, if you switch the patient to an anti-resorptive drug, and in this study they used raloxifene, you maintain your gain. So here at the spine, this group was switched from teriparatide to raloxifene, and they maintained it, whereas if they were switched to nothing, they lost bone, and we saw that quite a bit here at the hip. They also said if you kept taking the teriparatide for all 2 years, you continued to gain bone, but at some point you're going to have to stop it, and then you need to use either bisphosphonate or a raloxifene in order to maintain this gain. That's about all we have on long-term teriparatide. And interestingly, even up until now, there's no studies about what happens if you wait a few more years and then retreat. And I think partly it's because there's still this black box warning about cancer that has discouraged any long-term studies of teriparatide. So now we're going to talk about denosumab. This is, of course, a very popular drug right now. It's advertised all the time on television, much to my dismay. It does increase bone density. It does reduce fractures within the first few years of use. It does stop bone resorption and almost completely stops bone formation. And with this drug, as with bisphosphonates, we are seeing atypical fractures and jaw osteonecrosis with prolonged use. But since it hasn't been out on the market nearly as long, there's not very many cases because there aren't very many people who've been on it for longer than 5 years. But the worrisome thing about this drug, and I'm going to talk about it at length now, is that there's a rebound loss after it wears off. And this is really dangerous. This is an example. This was all the subjects from a center in Switzerland that had been on the initial randomized trial of denosumab or placebo. Look what happened to their bone density of the spine. During the study, it kept going up. And this group had started with denosumab at the beginning. This group was on placebo for the first 3 years and then took the denosumab. And at 10 years, or 7 years of treatment in this group, or 10 years in this group, they stopped and they got this pretty rapid loss at the spine. At the hip, it was even worse, and they went down considerably lower, 6% lower than when they started out. Not only did they go lower than when they started, but they lost it all at once within a year. What happens when you're resorbing bone that quickly? You can get fractures. Here's just one other study showing the same thing, the percent decline in a different group, 8% of bone loss after you stop. And all this loss happens within 6 to 12 months. Well, there's now accumulating reports of multiple vertebral compression fractures during that 6 months of rapid loss. This was one example of a woman who also was on aromatase. She had improvement of the bone density, so they stopped it, and in 6 months, she had this whole series of fractures. Here's another case that I saw in my clinic where the patient only skipped a dose, and she had been doing so well, her bone density was going up, but she didn't have any fractures. She had nothing else wrong with her, but she came in with this whole series of fractures, and we did a complete workup. There was no other reason for this except that she had skipped her dose of medication. Looking at the results of one of the large studies of the patients or the subjects who had dropped off of the denosumab, you could see that the dropouts off treatment weren't all that different from placebo and denosumab when you looked at the single fractures, but when you looked at the multiple fractures here, denosumab on treatment had very few, but off treatment they had a high rate, and it was even higher than if you were on the placebo. So they're having significantly more fractures like this. So what are the clinical features of these patients who get these spontaneous multiple vertebral fractures? The average age in one cohort was 66. They got their fractures anywhere from 7 to 20 months after your last injection. The median was 11 months. Vertebroplasty seems to really make it even worse. So they had 12 women had 58 fractures in the following days after vertebroplasty. So don't treat these fractures with vertebroplasty. This is a newer list of risk factors that have been discovered in what are ongoing recent observations. Risks are if you have a prevalent vertebral fracture before you start denosumab, the longer you take it, the more fractures you get when you stop it. The longer duration off therapy, I think that just means that you don't see as many right away after you stop it. After 6 to 10 months, it goes up. The ones who gain the most seem to lose the most. And the younger age group had more than the older age group, interestingly. I mentioned vertebral fractures. And it's possible that prior bisphosphonate treatment is a beneficial factor, and we're not sure about that yet, but it may be preventing some of the fractures. Why is this happening? So this is a biopsy study of patients who had never been treated while they were treating with denosumab, and when they discontinued, looking at resorption. So this is an osteoplast. You can see there's a little resorption here. There aren't any resorbing surfaces when you're on treatment. But when you discontinue, you start to get a whole bunch of scalloped resorption and large osteoclasts. The CTX marker, before you start treatment, is on the high side. When you're on denosumab, it goes way down. When you stop it down, it's way up, and it goes much higher than what they're calling the physiological maximum. So it's not just a loss of effect, it's a rebound. And you don't even gain volume. This is interesting. While you're on treatment, you're not losing bone, but you're not gaining bone either. You're just keeping it where it is. And when you stop, however, you're actually losing bone. Also, interestingly, when you look at the osteocytes, there's some differences. So this is before treatment, the number of osteocytes that are mineralized. This is while you're on denosumab. And then there's still some high ones when you discontinue. So while you're on treatment, these osteocytes actually are dying off, and the spaces are filling in with mineral. And that seems to weaken the quality of the bone. Another very interesting finding that might explain this rapid bone loss is called osteoplast recycling, that has only been seen in the situation of taking denosumab. So normally you have circulating pre-osteoclasts, and when they're exposed to rank ligand, they fuse and make osteoclasts. And then after the osteoclasts have resorbed the bone, they undergo apoptosis, and that's what naturally happens. However, if you inhibit rank ligand, what they've seen is that the osteoclasts, instead of doing apoptosis, they turn into what we're calling fission cells. It's the opposite of fusion cell. You actually break the cell back down into little cells. These are unique. They haven't ever been described before. They're not the same as pre-osteoclasts. So we are naming them fission cells. And when the rank ligand inhibition stops, they suddenly and quickly can fuse up and start working. So they're really all set, ready to go. And they're now finding that these fission cells accumulate with duration of treatment of denosumab. So it's like a dam of these cells all ready to attack your bone as soon as you release the inhibition. Just a couple other examples. This one was a patient who had been on bisphosphonates. She had 14 doses.
I just want to stop a minute. She'd been on denosumab. I misspoke with bisphosphonates. So she'd been on denosumab for a long time.
And she actually only missed 2 months. So she was due in November. In January, she got 2 new fractures. And these were symptomatic fractures. And so they quickly gave her another dose of denosumab, hoping that that would prevent getting any more fractures, but it didn't prevent it at all. Only 3 months later, she's now got a fracture in 4 more vertebrae. So you can't prevent this by giving more denosumab. You can only attenuate it with zoledronate, but you really don't stop it. So this is what happened in one study. You got denosumab, then you switched them to zoledronate, and their bone density came down. And in this case, came down to lower than when they started, even with zoledronate. This is a study that shows what happens. It wasn't really designed to look at what happened when you stop the treatment, but they'd done switching with denosumab and teriparatide in various different ways. And what I want to point out here is this yellow line. In this yellow line, the patients were treated with denosumab for the first 2 years, and then they were switched to teriparatide, and they decreased the bone density. So switching from denosumab to teriparatide is actually not a good idea. And that's not going to solve the dilemma. Here's the femoral neck, here's the total hip. You're seeing it also in the radius, even worse. And in the spine, you recover a little bit. So you can't switch, you can't give them more denosumab, you can't switch to teriparatide, you can't really switch to zoledronate very well. What happens if you switch to romosozumab? So this was just a single case report of somebody who'd been getting denosumab for 6 months, and at this point they stopped and decided to switch over to romosozumab. But look what happened to the trap. That's an alternate way of measuring bone resorption. It started zooming up after the last dose of the denosumab, and pretty soon she got severe back pain. And here's her x-rays showing that she'd had all these new fractures when they switched from denosumab to romosozumab. So you're really in a bind. At this point, it looks like the best thing that you can do is attenuate it with zoledronate. That seems to be better than not doing anything, but it still is causing some of the loss and some of the fractures. And so we're just waiting more studies. There's quite a few of them piling up about what you're going to do about this. The company just says, well, don't ever stop. That's not such a good idea either, because then you may get the same kind of atypical fractures and osteonecrosis of the jaw that you do with prolonged bisphosphonates. So it's a dilemma, and probably the best and wisest course is just not to start in the first place. If you're going to need to end up with a bisphosphonate, then why don't you just start with it? I want to make a special call out to the chronic kidney disease that I hear all the time, well, you can use it in CKD because it's not metabolized by the kidney. And I say, well, being not metabolized by kidney is not an indication for a drug. What happens if you do use it, and especially the grade 4 or 5, is there's a high incidence of serious hypocalcemia with reports of problems like seizures, laryngospasms, arrhythmias, and tetany, and requiring several days of ICU with calcium drips. There's no randomized trials in patients with late stages of CKD, and we don't really know the effect on vascular calcifications. Here's just another study showing that you can get really very severe calcium after you give this drug. And one worrisome case report of a rapid progression of vascular calcification. So the patient at baseline had a CAT scan of the heart and the abdomen, and there were no calcifications. She was treated with denosumab, and the calcium went down, so it was counter-treated also with calcium and and by 4 months, you're starting to see calcifications. And by only 10 months, you can see the marked increase in calcifications of the coronaries and the aorta. So this is a rapid progression of another very serious side effect, which is another reason why you might not want to give denosumab to patients with chronic kidney disease.
Okay, so can you all hear me all right? So
Yes.
that's actually the end of the formal part of the presentation, and I'm just gonna sort of sum it up that we have a lot of experience with long-term bisphosphonates, and it doesn't look like it's necessary to use them more than 5 years. And at least for the next 5 years, we know that it's okay to just stop. And what we don't know is now we're seeing, because they've been out a long time, people who've been on 5 years, then off 5 years, and then what do we do? And there's just virtually no data at all about what to do then. So what I do in my clinic is follow the urine NTX values. And if they stay low, which they may stay low for a long time, then I just follow them. And if they start to go up, I will restart either bisphosphonate, or sometimes I start with the low dose, or sometimes I will give them raloxifene if they would be candidates for that. With the denosumab, I want to go a little bit more, and Julie brought this up, that there have been several different studies now of giving zoledronate at different time points, because there's a notion that if you try to give a bisphosphonate while you have zero resorbing surfaces, then the denosumab has no place. I mean, the bisphosphonate can't attach to the bone, so it just basically doesn't attach, will come right out in the urine, and it won't work. So that you need to wait until you have some resorption. Then you can give the zoledronate, and it has a way to attach. However, the most recent study did show that if you, their protocol was one group randomly just got it immediately after the last dose of the denosumab was, or when the dose was due. The second group, they waited a couple of months and then gave it. And the third group, they monitored the NTX and didn't give it until the NTX had gone up. Now, all of the people in this study had been taking the denosumab for 5 or more years. And they all lost over 5%, and they didn't really have, it didn't really help even to wait. So the notion that you're going to be able to prevent the bone loss with zoledronate by waiting 2 months after you stop the denosumab is not really bearing out in people who have taken the medication, the denosumab, for a prolonged time. And there's also 6 or 7 studies that look about what happens if you've taken it for 1 to 2 years. And if you've only taken it for a couple of years, then giving a bisphosphonate afterwards does help to prevent the loss. So you have to look at how long they took it before you gave them the Zolodronate, and it's rather discouraging that even with giving the potent bisphosphonate, you're getting this rapid bone loss. It attenuates it a little bit, but it doesn't prevent it.
Susan, I think on that light in the questions, Mark Wenner had something that fits in there of, how do you manage, he says, how to manage patients completing teriparatide or DMAB or Romo who've already received 5 years of alendronate prior. He's taking to heart, the concept of maybe 5 years is plenty of bisphosphonate, in the patient you were just talking about, maybe comment on that. And then he also asked, would a SERM or estrogen, in the appropriate patient, would that be potent enough or not? And then I'll just add of whether you'd comment about someone who's eligible to use oral bisphosphonates without a contraindication to oral following DMAB, whether you'd comment on that.
I'm trying to remember. I'm trying to remember if there were any studies using oral. I think there were, yeah. There were a few studies of oral bisphosphonates, but they had only been on denosumab for just a brief time, 1 to 2 years. And so I haven't seen them use the oral ones because it's felt that they don't act quickly enough when you're getting this really rapid crash in the bone density. I have not seen anybody try the SERM. Well, the only SERM we have is raloxifene that we could use. And most of these women are going to, if they're women, most of them are going to be beyond the age of when it's safe to start estrogen. A lot of times you're not getting the kind of serious osteoporosis until you're in your 60s and 70s. And it's not really safe from a cardiovascular point of view to give, to initiate estrogen in a woman, or it hasn't been, I haven't seen any studies in testosterone in men after this. So there's a lot of, this is an area where there's still dilemmas and no really good answers about what you do. And so right now, and this is going to, I'm sure the advice will change as we get more data, but if there you are sitting there in the clinic and you got somebody who's been on denosumab for 5 years, you're going to have to do something. So I'm saying that what I'm doing is waiting 2 months after they were due for their last dose, then I give them a dose of Zolodronate. And it's particularly challenging when they have chronic kidney disease because their doctor thought, oh, well, we can give denosumab because that's safe. And we don't have to worry, and we can't give bisphosphonate. And so now you are boxed in to the worst of two evils. I figure it's better to give Zolodronate than to let them have this very rapid bone loss. But I do give it more at a lower dose, depending on the degree of kidney disease. And I give it over a longer time. I might drip it in over an entire hour. Because it seems like that's the best choice, but we're now getting into the realm of nothing but expert opinion about what to do, and I think that we should really be very much more cautious about using this drug in the first place. You might as well start out with the bisphosphonates. Let's see, any other questions?
Dr. I did want to note that Dr. Weisham's question she asked in the chat, I don't think the rest of the attendees saw it, so it might be good to go over that one again.
Sure. So this was about the FLEX study. And in those days, they were taking the drug every day. And so the question was, were they compliant? And during the study, the patients were contacted every 3 months by the nurses. They were counseled extensively. And the ones who got into the FLEX study were the compliant ones. They were the ones that had been taking it all along for 5 years, and they just were definitely in the habit of doing it. So we think that compliance really was good during that study. And that doesn't explain why the placebos look the same as the alendronates.
I think there was a question from Dr. Starkeybaum. He's the only one of us as a rule follower this morning. He put it in the Q&A. It said, can you compare estrogen therapy with bisphosphonate therapy? And Gordon, I know that Susan at the beginning talked about estrogen being as good or better for both fractures and BMD, et cetera. I don't know if you want Laura to put you on video and you could clarify or oh, he raised his hand. Laura, let him in.
Okay, just one second. Let me find him. Okay, allowed to talk.
I see.
All right, Dr. Starkeybaum, you should be able to.
So, in other words, it sounds like estrogens are a reasonable alternative. Maybe after denosumab, I don't know when. I gather the ACP and everybody else, though, is worried about coronary disease and uterine cancer and everything else. So it's not recommended. But we're stuck.
Yeah, so I'm quite aware that estrogen is not recommended. And I basically really disagree with that. And I think the people who don't recommend estrogen have a bias against it. There definitely are problems with if you give the estrogen to women who already have cancer. And there are problems with uterine cancer that you can basically treat with progesterone. But the limitation of estrogen is that you need to give it to women who are within 10 years, and I feel safer within 5 years of menopause. So once the Women's Health Initiative came out, I no longer started women on estrogen unless they were, in this little 50 to 60 year old range. And most of the patients that we're seeing who are treated with denosumab are the ones who have more serious osteoporosis, and they do tend to be older. So if you had somebody who was in that young age range, then I would consider estrogen, but I guess I haven't felt comfortable starting women on estrogen because of the issue with coronary artery disease. If they're older than, and it really is very important how old they are when you start it. I think what we need is to bring back some of the other SERMs. I don't know if you remember lasofoxifene. That was a more potent SERM than raloxifene. It reduced, not only did they have half as many spine fractures, they had about half as many breast cancers, about 40% reduction in hip fractures, and 20% reduction in myocardial infarctions. And yet, because of a kind of a crazy, unlucky quirk in the risk of all-cause mortality only in the low dose group, no problem with mortality in the high dose group, the drug was abandoned after a really large 5-year study. I don't know if there's any way to bring it back, but it's like I want it back to try in some of these other situations.
Thanks. Well, I've got you. What about the issue of post-hip fracture ignoring osteoporosis treatment? Whose responsibility is that?
Yeah, well, that's a big problem, actually. Well, Julie has started the fracture liaison service, and from all that I've been able to tell, that seems to be one of the best answers. Is you hire a nurse who will track the patients after their fracture, get them to a clinic. A lot of people think it's best to start the drugs when they're coming in for their 6-week follow-up visit, not immediately in the hospital, and really get them plugged in to treatment. And when you do those, if you're looking at the studies of patients who have these kind of services, now we're seeing a much improvement. You're getting more than half the patients. We still have a ways to go. There's always going to be some who give up, and there are a lot of reasons why you don't. And I think like Sue and Julie can tell you some of those stories, but just being aware, and the orthopedists are starting to get a little bit more aware of it, but they don't really want to do the treatment, and stop thinking that it's an untreatable disease. It's still something we can really make a benefit.
Thank you.
Susan, this was wonderful. I know we're at time, and people that have additional questions, hopefully you won't mind if they reach out to you through your regular UW email, or I think Dr. Wong, our second year rheumatology fellow, is with you this month. He was with Dr. Cram and I and our Strong Bones team here at UWMC Northwest this month. So he can be our kind of liaison. So you guys working with Irvin in the clinic, you can funnel your questions to Dr. Ott that way too, and then pick her brain through him. And again, we really want to thank you. And I'll hand it to Laura.
Yeah, so we are all set. We will be recording this lecture and posting it on our website. So I'll send it around as well. And Dr. Ott, I'll share it with you. And thank you so much for joining us today.
Oh, well, thank you guys for coming and listening. Okay.
Bye,
Bye.
everyone.